Thank you everyone for joining us this afternoon. I have the unique pleasure of introducing my direct supervisor as our speaker today, which is Seth Brown. He's a relationship-oriented, disciplined, and strategic-minded attorney and government relations professional who specializes in healthcare law. Brown serves as the Director of Government Relations, leading IMS's advocacy efforts at the Capitol. In his role, he educates on and represents the interests of Iowa physicians to state and federal lawmakers, regulators, and other stakeholders in the healthcare, legal, and health insurance spaces. He also oversees fundraising efforts for the Iowa Medical Political Action Committee, or IMPAC. And previously, he served as the Director of Public Affairs for the Iowa Pharmacy Association, or IPA, where he led their advocacy efforts and focused on regulatory and insurance reform impacting pharmacist practice. During his time with IPA, he was sworn into the Iowa Bar and he maintains that Iowa license to date. Brown graduated from Drake University Law School, where he specialized in the legislative practice program. As part of this program, he worked one session in the Iowa House of Representatives under Representative Bobby Kaufman and one session in the lobby with Mr. Michael Triplett. Thank you again, Seth, for being here today to talk us through your expertise, really. And I will go ahead and hand things over to you. So let me stop sharing my screen.
All right. Well, thank you, Christina. Thank you for that very robust introduction. I always I don't know if enjoy the introductions, but Christina always does a great job with these webinars. So I do appreciate the time and the invite to come on and talk to everybody today. As mentioned, I am Seth Brown. I'm the Director of Government Relations with IMS. So I do oversee all of our legislative advocacy, regulatory advocacy, and lobbying for the society. On a day-to-day basis, when the legislature is in session, I'm up at the Capitol in the State House, and I'm accompanied by our policy analyst who's on the call today, Charlie Murphy, who gets into the weeds on the policy and clinical impacts of any legislative or regulatory proposals, but also our two contract lobbyists, Matt Eady and Kate Walton, who have over 50 years of combined experience at the State House, and they advise me on a lot of the political dynamics. So we have a great team up at the State House representing IMS and Iowa physicians across the state. So we're really lucky to have such a robust team. As Christina mentioned, I am an attorney. With that being said, I'm not each of your individual attorneys, so this information that I'll be presenting is not legal advice. And ultimately, we'll have to wait and see how the various boards and agencies implement and interpret many of the laws before I can comment on specifics on a case-by-case basis. But I will present what is included in the laws and how we expect them to roll out. Obviously, there is a legal process that we'll have to see through, but I do just want to make that caveat in that mention. So today I will start by giving a broad overview of this past legislative session and talk about some of the legislative makeup and the overall context of the session. And then we'll go into some of the bills that IMS was actively supporting that did get over the line. We'll talk about a few of the other bills that IMS engaged on that were also passed and signed into law. And then we'll take a little bit of time at the end to talk about some of the new residency funding announcements that have come out. Very exciting stuff there, so I look forward to chatting about that. And then we'll leave a little bit of time at the end for some questions and answers, and we can dive into some of the specifics at that point. So to start, as mentioned, I'm going to provide kind of a 30,000-foot overview of this legislative session to provide some context of what we were working through throughout the session. Starting at the top, the second session of the 91st Iowa General Assembly kicked off on January 12th, 2026. The session lasted for exactly 112 days. This is 12 days over the scheduled 100-day mark when legislators' per diem payments eventually run out. We saw in the final push a 35-hour overnight marathon on Sunday, May 3rd, to finalize several agreements on policy proposals that were yet to be finalized, things like property tax and several other policy and priorities from the legislature as well. So very, very active session. The IMS advocacy team was at the Capitol around the clock in the final hours. I'd say you had several zombies walking around trying to pass bills and advise on bills as we were in the final 35 hours. So we were happy to be there, but I was definitely happy to get back to bed after that long push. As I mentioned, this session was extremely active across the board, but healthcare did remain a top priority. Specifically, this legislature focused on how to reduce administrative burdens to try to maximize the time of the healthcare workforce. So we were very excited to see several bills in that direction get over the line that we'll talk about today. A little more context on how active the session was. This session, we saw over 1,085 bills introduced in the House chamber alone and 706 bills in the Senate alone. So that comes up to a total of about 1,791 individual pieces of legislation that were introduced and considered in the legislature this session. This is not a record. Last session, we actually saw more, but we are on the second half of a two-cycle legislative assembly or general assembly. And so the fact that there were that many bills introduced and considered is pretty impressive. Each of those are individual policy ideas that would change Iowa law. So we actively engage on any that fall into the healthcare space or in the area that might impact physicians. So in total, we registered on about 140 bills, but we did actively monitor several more beyond that. That is a lot. 140 is a lot for a group like IMS that has one specific area, subject matter area. So very active, but very engaged throughout the process. It's also important to mention and consider the makeup of the legislature, as this does determine the trajectory and the likelihood of passage of all of our priorities and other groups' priorities. The makeup of the legislature this session, we saw the House had a Republican supermajority with 67 Republicans and 33 Democrats. Essentially, what a supermajority means in effect is that House Republicans could operate without any Democrats present because they can independently meet a quorum. So that is functionally very important for the lobby and advocates to keep in mind. We do have to appeal to, who is actually voting and who has the votes to pass bills. In the Senate, we also had a large Republican majority with 33 Republicans and 17 Democrats, but they were just short of that supermajority number. So every once in a while, there was the need to pull from the other party's votes. In light of this, the majority party did place a very large focus, as I previously mentioned, on administrative burden reduction and trying to bolster the rural healthcare workforce. We saw several proposals that were in line with IMS priorities that I'll talk about. But regardless of political affiliation, at the end of the day, IMS works with all elected officials that are making policy that impacts physicians. Fortunately, especially when it comes to the physician workforce shortage, it is a bipartisan issue that impacts both sides of the aisle in both rural and urban. So everyone wants to address that, and we have made great progress in the legislative arena in light of this. And with that being said, a huge part of what IMS does is advance affirmative bills that I'll talk about in just a moment. That is a critical role that we play, but we also do play significant defense to protect the practice environment. For example, IMS actively amends or tries to prevent the passage of bills that would directly or indirectly impact the physician workforce, whether that be administrative burden increases or placing additional pressures on the physician workforce in the practice environment. This slide just shows a few of the bills that IMS opposed and successfully defeated. I'm not going to talk about all of these, but I just want to call out a few to remind everybody that there's a lot more that IMS does than just pass affirmative bills. We're also trying to prevent or amend bills to make them workable throughout the process. One bill that caught a lot of our members off guard and got a lot of attention from our folks was House File 2171, this K through 12 vaccine requirements bill. This bill would have strike the requirements for elementary and secondary students to be immunized as a condition of school enrollment. This wasn't necessarily on its face a workforce bill, but it was something that IMS quickly viewed as a workforce bill because it would have definitely exasperated the already strained healthcare workforce in the state. So we do engage heavily on bills like this that would hinder prevention tools like vaccines. So that bill was successfully defeated. We also saw a bill that would have required pharmacists to dispense ivermectin and hydroxychloroquine upon request from any patient over 18 years old. We partnered with other allied groups to successfully prevent this bill from passing in this version. And so that was another one that we heard a lot about from our members, and I did just want to call out that one. One other interesting bill that I expect will come back in future sessions was this House Study Bill 766, which would have established a new regulatory framework for licensing, oversight, and reimbursement of AI autonomous service providers in clinical healthcare settings. So essentially, this bill would have allowed fully autonomous medical providers to practice and then establish a new board separate from the Board of Medicine to regulate them. And so we did speak to some of the concerns we had with that. We also spoke to some of the benefits of AI, trying to advise. That bill ultimately did not pass either, but that is something that we were actively monitoring and engaging on. One last one from this defense section that I want to mention is the House and Senate File 2455, the No Surprises Act carve out. This bill was floated by the insurance industry and provided that out-of-network physicians would either have to accept the in-network rate or 150% of Medicare, and only emergency physicians could appeal for 25% more. It also established an arbitration process to resolve disputes over these payments, and that would have effectively carved Iowa out of the federal No Surprises Act independent dispute resolution process. So this would have added a lot of administrative burdens. It would have also created a lot of confusion having a separate dispute resolution process. Ultimately, this bill did not pass. This was floated in response to an insurance bill that we did successfully get over the line. But that was another piece of the defense that we played that we were very happy to see not advance this legislative session. All right. Moving on, in general, all the bills that passed during the legislative session and signed by the governor that don't specifically state an effective date usually go into effect on July 1, 2026. So each of these, I will note, whether the bill specifies an effective date or not, or whether it's the standard assumed date of July 1. With most of these, the various regulatory entities and the boards may have rulemaking authority, so I'll try to note that as well. Rulemaking by these entities could delay some of the implementation, or it may not be totally clear on when the final date of implementation will be stood up. But regardless, the bill is, and the bill language is effective at that time. I'll try to note and provide clarity as we go along on some of these bills, but there might be some ambiguity around ultimate implementation and applicability. All right. And getting to some of the affirmative bills that IMS actively supported this session. As I mentioned, the healthcare workforce has been in the spotlight legislatively the past few sessions, from tort reform in 2023 to residency and loan repayment funding in 2025. There has been a lot of effort to attract and retain physicians to the state, and also maximize the time of physicians already practicing here. With that, that was definitely true this session as we're looking at many of the bills that did ultimately pass the legislature and were signed into law by Governor Reynolds. To start, I'll briefly talk about House File 2635. This is an insurance reform bill, and essentially prior auth and other insurance bureaucracy has been, I would say, the top pain point that we at IMS hear about from our members when it comes to the administrative burden discussion. We partnered with other leading healthcare organizations, including the Iowa Hospital Association, in an attempt to address this, ultimately so physicians could spend more time with patients and less on paperwork. Some of the specifics of this bill would expand requirements for health insurance carriers by ensuring that only physician peers may deny or downgrade prior authorization requests. Essentially, you have to have a clinical peer in the same or similar specialty that makes that determination. The bill also exempts cancer-related screenings and emergent conditions from prior authorization requirements. in light of our very high cancer rates. This was, in our opinion, a no-brainer for the legislature, and they were very excited to see some legislation that would ensure that patients receive that care without delays. The bill also prohibits carriers from penalizing providers for affiliating with out-of-network providers. We saw several contract requirements from the insurance carriers over the past interim that would have hindered referrals that were coming from out-of-network providers. And so we did include language in there to ensure that providers were not penalized for ensuring that patients got the care that they needed. The bill also bars enforcement of unreasonable contract terms with providers and requires negotiation on contract agreements or amendments, essentially banning take it or leave it contracts. There were also requirements relating to audit timelines from insurance carriers, as well as a requirement that all AI determinations from an insurance carrier for prior authorizations do have a human actually analyzing those before they are denied or downgraded. So that was something else that we heard a lot from our members that was included in the final bill. The picture that you see on the right here is at the bill signing at Monroe County Hospitals in Albia with Governor Reynolds and our two champions on this bill, Representative Austin Harris and Representative David Young. We also had Senator Carol Warmy, who championed this bill but was unable to make it. This bill goes into effect on July 1. It went into effect on July 1. It did grant the Iowa Insurance Division rulemaking authority. So there are some aspects that are continuing to be built out that we are yet to see that the Insurance Division will be working through. One aspect that we were able to accomplish in a bill last session had to do with insurance and prior authorization complaints. We have a page, IMS has a page on our website that provides more information on payer complaints and prior authorization enforcements. So I encourage you to look at our website and read more on what types of practices are not allowed. That will be updated as this bill goes into effect. And you will be able to get directly to the Iowa Insurance Division's complaint page so that you can submit complaints if necessary. So July 1 is the effective date for that bill. Very exciting to get that bill over the line. It was an extremely comprehensive bill that we partnered with other providers on. So I'm very excited to see that get over the line. The next bill is Senate File 2184. This bill has to do with physician licensure. This bill allows applicants to use a designee to complete a physician license application or renewal paperwork. It also updates licensure renewal from every 2 years to every 3 years, and it requires the licenses to expire on the licensee's birthday. Lastly, the bill also sets some notification and determination deadlines for the Board of Medicine. This bill was ultimately adopted by the legislature to cut back on some of the paperwork and speed up the process in the licensure space. The effective date for this is July 1, 2026. We do expect the Board of Medicine, they are tasked with rulemaking, so we'll see if what the timeline will come on that, but those are the updates that have been passed into law. Another administrative burden bill that did get over the line. Next on the list, we have Senate File 469. This is an emeritus physician license bill that was also passed and signed into law. This bill creates a new licensure categories for physicians over 60 years old that are primarily engaged in teaching and training and supervising resident physicians. This was a recommendation that was included in IMS's Operation Iowa report in an attempt to, one, attract new resident preceptors so that they can fill some of those residency training slots, but also to encourage near end of stage physicians to stay in practice and continue to provide care. So the license would reduce the renewal and application fees in half, and it also exempts licensees from CME requirements. And it also allows holders to maintain their previous scope of practice. So this is a license that will be limited to 3 years with one renewal, and that went into effect upon enactment no sooner than January 1. So July 1 was that first that effective date. And this bill also directs the Board of Medicine to adopt implementation rules. Next on the list, and I'll try to go through these next few a little bit quicker here. House File 2434 is the out-of-network coverage bill. This bill really seeks to promote direct primary care in the state of Iowa. It bars health carriers from denying coverage solely because the referral came from an out-of-network primary care provider. And it also prohibits insurance carriers, from imposing deductibles, coinsurance, or co-payments that are greater than those that would apply if the referral came from an in-network professional. So carriers are allowed to require the primary care provider to furnish evidence of a direct primary care agreement with the covered person. But ultimately, this came as a result of some of the contract changes that we saw over the interim prior to session. And this is something that many of our direct primary care providers encouraged us to support. The effective date on this applies to referrals made on or after July 1, 2026. And the Commissioner of Insurance is also permitted to adopt implementation rules for this bill. The next bill is House File 2562. This is a temporary guardianship bill that was signed into law. This bill addresses situations where adult patients receiving care in hospitals, clinics, nursing facilities, rehab facilities, or residential care facilities cannot consent to their own placement and have no available authorized representative. So the chapter specifically authorizes a licensed physician to certify a patient's inability to consent. It then permits a person authorized to consent, which could be a spouse, adult children, parents, siblings, and it sets the priority for that. It allows them to make placement decisions and assist with insurance or public assistance applications. It also requires care facilities to help identify appropriate receiving facilities and provide a court-ordered petition process when no authorized person can be located. So ultimately, there was an attempt to ensure that patients received the appropriate care that they needed and to speed up that process. This puts physicians in a temporary decision-making position so that they can help their patients get the appropriate level of care. The effective date is again July 1 on this bill as well. And the last one I'll hit on here is House File 2564. This is a minor consent to pregnancy care bill. This bill also passed and was signed into law. It provides clarification by expressly granting a pregnant minor the legal capacity to consent to prenatal, intrapartum, or postnatal care when a parent, guardian, or legal custodian is not reasonably available. So the consent may be given to a range of medical professionals, from physicians, their designees such as ARNPs, PAs, registered nurses, and others. The bill also clarifies that this grant of consent authority does not relieve providers of their independent duty to obtain informed consent from the minor patient before providing that care. We were hearing from several providers that were along state lines that they had pregnant minors coming in without their parents or legal guardians, and our physicians were unable to care for them due to this quirk in the law. And so it often resulted in referrals out of state across state lines. And so this bill that was drafted by Iowa ACOG sought to address that. This bill was, as I mentioned, passed, and it has an effective date of July 1, 2026, so that is currently active. So these are just some of the bills that IMS supported throughout the legislative session. It's far from a complete list. And we'll hit on a few more bills that we were actively monitoring and engaging on in just a moment. But this is a huge part of what IMS does, actively engaging on those bills that would improve the practice environment by reducing administrative burdens, providing clarity, or just ultimately improving the practice environment. So we were happy to see all those get over the line. And again, I want to thank our legislative champions on this bill. We had several great efforts from folks like Representative Austin Harris and Senator Warmy and others that stepped up and heard some of the concerns that we had, and were very active in advancing these bills, as were the whole legislature. And then the governor ultimately signing that and all of these into law. So very exciting stuff on this end.
Seth, before we move on to the next
Mhm.
slide, we do have a question in the chat.
Sure.
From Dr. O'Shea, does the emeritus license bill allow for teaching of medical students rather than residents? I have a retired physician who practices at my free clinic and teaches students in that setting.
Yeah, right now the language applies just to residents. I think there would be an appetite to expand that beyond to just residents. But as of now, the language just applies for medical residents.
Thank you.
All right, and now I'm going to touch on a few other notable bills that came through the legislature this past session. I will try to go through these as quickly as we can, but there are several, so I might skip around a little bit as we go through. And also, as I mentioned, we declared on over 140 bills, and there were others that we were monitoring. So this is not a complete list of bills. This is just a few that I think are most relevant. And at the end, if there are others that aren't on this list, I'd be happy to talk through those as well. The first one on the list is House File 2739. This is an HMO tax bill. Coming into session, the Nonpartisan Legislative Services Agency, or LSA, that provides bill drafting and fiscal analysis services, estimated approximately a $90.6 million budget deficit in the Medicaid program for 2026 in the state of Iowa. So the legislature passed this legislation to establish a new 3.5% healthcare related tax on health maintenance organizations, or HMOs, that operate in the state. The bill uses funds from the new tax to appropriate the full cost to HHS for medical assistance under the Medicaid program, as mentioned, to cover the totality of the 2026 budget, Medicaid budget specifically. So IMS pays close attention to this because we are actively monitoring physician reimbursement under Medicaid and ensuring that reimbursement is up to the level of practice expenses. This has been an ongoing issue that we've heard about from members when it comes to low reimbursement, and it's been a hindrance to recruitment and retention in the state. Ensuring that the Medicaid program is fully funded is an interest of IMS. This wasn't necessarily something that IMS actively supported, but we were paying close attention to see how that budget was going to be funded to ensure that reimbursement was fully funded for physicians. We will continue to actively advocate for physician reimbursement that's up to cost. And I'd say that's going to be an even larger priority for us moving forward into future sessions. We have heard a lot from members on this, and we certainly see the deterrence that low reimbursement is when you're looking at other states to practice in. So that is top of mind for us. For the HMO tax specifically, most of this bill takes effect immediately upon enactment. The legislature is implementing this tax to leverage federal matching funds from CMS. So that does require federal approval. The temporary provision imposing the 3.5% healthcare tax rate for January 1, 2026 through September 30th takes effect when the Department of Health and Human Services notifies the General Assembly that CMS has approved the new tax. And so there are some back and forth requirements there. But in short, the act generally takes effect upon enactment. And then Division 1 of the bill applies retroactively to January 1, 2026. And that temporary elevated HMO tax provision has a CMS approval contingent effective date. And so it will apply retroactively upon approval from CMS. Either way, it is funded. Medicaid has been funded. So that is, I would say, good. Next, Senate File 2480. This is a vape tax to be used for pediatric cancer. This bill essentially broadens the scope of Iowa's tobacco laws by including nicotine analogs in the definition of alternative nicotine and vapor products. And that would include vapes that are subject to this new excise tax. So as a result of that, about $3 million in new tax revenue is going to be appropriated annually for pediatric cancer research and related activities at the University of Iowa Stead Family Children's Hospital. Obviously a great need and a huge focus with Iowa's high cancer rates. That bill has an effective date of January 1, 2027. So it does take a little bit of time for that to kick in. That will be in the new year in several months. This is one of the few that did not have a July 1, 2026 effective date. So just want to note that. The next bill is House File 2676. This is the governor's MAHA bill. This bill implements very wide-ranging reform in Iowa's health, nutrition, and educational laws. Specifically, it requires physicians and PAs in certain specialties to complete 1 hour CME on nutrition and metabolic health every 4 years. It also requires Iowa's medical schools to include 40 hours of integrated nutrition coursework for graduation. The schools have indicated, and they did indicate throughout the process, that they already meet this 40-hour requirement, and UI already signed on to a compact to establish this. So that is one thing to note. The bill also permits ivermectin to be dispensed over the counter by pharmacists without liability. I bring this up mostly to distinguish this from the broader ivermectin hydroxychloroquine dispensing bill that was successfully defeated. This portion does just apply to ivermectin, and it allows pharmacies to do this. When we have talked to other states, and what we heard from other states is that many pharmacies do not ultimately take this up, and they don't choose to do it. I think Arkansas did it, and they saw one state that ultimately decided to dispense ivermectin. Either way, this does not apply to the hydroxychloroquine aspects or the mandatory dispensing that was in the separate bill. Other components of this bill relate to school meals, physical activity requirements in schools, and also screen time in schools. I won't take time to touch on those. They are a bit outside of our scope, but they are notable. It was a very wide-ranging bill, and one that I want to ensure that our physicians know about. Effective date on this: most provisions, including the nutrition CME requirements and ivermectin sections went into effect July 1, 2026. The requirement for med schools to teach 40 hours of nutrition and metabolic health coursework begins July 1, 2028. So there is a 2-year delay on that, but the CME requirements and the ivermectin sections did go into effect July 1, 2026. And so the CME section is 1 hour every 4 years. So make note of that. That is something that will be new as you're going through and renewing. Next, we have House File 2254. This is a UIHC non-compete clause bill. This bill requires the Board of Regents to create a policy that prohibits the University of Iowa hospitals and clinics from including non-compete clauses in contracts with physicians. The bill was also amended throughout the process to include advanced registered nurse practitioners, licensed practical nurses, pharmacists, PAs, and registered nurses. Under the bill, a non-compete clause is defined as any restriction on the professional's right to practice in a geographic area or for a defined period of time after termination of employment with UIHC. The effective date on this applies to all covered employment contracts entered into, extended, or renewed on or after the bill's effective date. This does not impact current contracts unless they are extended or renewed. And the bill did take effect upon enactment, and the bill was signed into law on June 2nd, 2026. And so that bill was effective immediately, but it only applies to newly entered, extended, or renewed contracts after June 2nd, 2026. So that is notable. That is different than the standard July 1, 2026 enactment date. And I do want to make sure everybody is aware of that, especially if you are a UIHC physician. Next on the list is House File 2788. There were several reproductive health related bills that were introduced this session that would have impacted the practice environment for OBGYNs and family med physicians. I'm calling this one out to highlight how IMS actively provided amendments to improve bills that have a higher likelihood of passing despite having some unintended consequences. This bill was drafted to address illicitly prescribed and supplied pills entering the state, but it included many provisions in its first draft that unintentionally targeted law-abiding licensed Iowa physicians. IMS negotiated amendments to remove $50,000 strict liability damage provisions, which would have been very counter to previous tort reform efforts. There were also provisions in the original bill that mandated clinical statements relating to medication abortion reversal, which is essentially legislating the practice of medicine and impacting the practice environment. And there was also a long list of, I would say, very cumbersome reporting requirements that were included in the bill. These provisions that I just listed were all removed before passage. And so the bill was significantly improved. The bill ultimately requires all abortion-inducing drugs to be dispensed in a healthcare setting directly to the patient, and it also adds several informed consent requirements that, in all honesty, my understanding is most of those are already required anyway, so it shouldn't impact that side too much, but the in-person dispensing is certainly a change. The effective date on this, House File 2788 does not include a special effective date provision, so it went into effect July 1, 2026. So that is something to note if you are in this area. Next bill is Senate File 304, excuse me. This is a minor treatment consent bill. This is a bill that was introduced last session that didn't pass last session, but carried over, and it would remove minor patients' authority to independently consent to the provision of immunizations for sexually transmitted infections. So minors retain the right to consent to diagnosis and treatment of STIs, but they must now obtain consent from a parent, guardian, or other authorized adult to receive vaccinations for these conditions. This bill has an effective date of July 1, 2026. So that is in effect. Consent from the parent will be required for these vaccines if the child is alone in those meetings, in those visits. Next to note is House File 2543, and I am coming up on time here, so I'll try to move quickly. Subacute care facilities. In Iowa, we have this unique legislative category for subacute mental health care facilities, and it's essentially a short-term mental health service provider offering a level of care that's more intensive than outpatient therapy, but less than acute hospitalization, with the ultimate aim of stabilizing individuals and transitioning them back to less restrictive environments. The bill requires facilities to develop an initial treatment plan with residents within 24 hours of admission, and it establishes timelines for insurance prior auth determinations for subacute mental health services. It also establishes an electronic system to track psychiatric bed availability for children. Lastly, it directs HHS to study the feasibility of providing subacute mental health care services and additional psychiatric inpatient services at the state mental health institutes at Independence, with a report that is due January 4th, 2027. So this bill went into effect upon enactment, which was May 2nd, 2026, so it is currently active. And the last one on this list that I'm going to cover is House File 571. This bill creates very broad protections for healthcare practitioners and institutions that refuse to participate in certain healthcare services due to ethical, moral, or religious beliefs. Practitioners and institutions exercising conscience in good faith are shielded from civil, criminal, and administrative liability under this bill. This does not, it also, healthcare institutions must still provide federally required emergency medical services under EMTALA. So I want to make sure that that is clear. Religious-based institutions are expressly authorized to make employment, staffing, and contracting and admitting privilege decisions consistent with their religious beliefs. So with that, the bill does require practitioners to notify employers of any conscious objections. This is one bill that was introduced last session and ultimately did pass this session after many changes and significant back and forth. The effective date on this was July 1, 2026, so it is currently active. All right, that is all of them on the other notable bills. The last thing I want to cover is residency funding. So workforce development has been a major IMS priority in the last few years, specifically efforts to increase residency training positions as a result of IMS conducting our Operation Iowa Summit in December 2024. So there have been several announcements in the last month about new funding for residency training positions. So I do want to make quick note of these with the information that we have so far. So to start, House File 2782 was the HHS appropriations bill, the HHS budget bill that passed this last legislative session. The HHS budget specifically appropriated $1.5 million for grants to create new medical residency programs in rural areas and $400,000 for rural psychiatric residencies specifically. These are the resident or the psychiatry residency slots are a continuation of funds to keep that program going. The effective date on this is the bills applies to fiscal year 2026 and 2027. So that begins July 1, 2026 and will go through June 30th, 2027. So those funds are eligible within that date and are currently active. The next is a very exciting announcement that was made very recently. So as I mentioned, following IMS's Operation Iowa in December 2024, we advocated for increased funding to expand residency training opportunities in the state, knowing that we were, as a state, a net exporter with two great med schools that were short on medical residencies. We saw the need in Operation Iowa. Participants saw the need to expand those residency training positions. So immediately following our Operation Iowa recommendations, Governor Reynolds and the department requested funding from CMS through a state plan amendment to draw down federal funds for this purpose. On June 5th, 2026, the Department of Health and Human Services, along with the governor, announced CMS had approved the Medicaid GME program expansion. They announced nearly $88 million to be used for rural healthcare initiatives broadly, and $49.5 million in additional funding that's earmarked for residency training positions specifically. We expect that that'll create at least 128 new positions at Iowa's 13 teaching hospitals as a result of those funds becoming available. And to continue with the good news, $10.5 million has now been announced for new state grant initiatives. So on July 24th, just a couple days ago, Governor Reynolds and the department announced an extra $10.5 million specifically for rural residency programs in the state. An RFP has been issued and information for applying can be found on HHS's website. Eligible applicants can apply to develop residency programs in internal medicine, OBGYN, general surgery, and psychiatry, I believe, so long as the program would be in a federally designated rural community. I just want to say this is all very exciting to have those funds. The state has been very responsive to our calls to action on this, and we recognize that physicians are much more likely to practice where they do their residency training. So although this is a long process, we are seeing a lot of great movement in the right direction, and we are happy to see a lot of those recommendations being adopted following Operation Iowa. We look forward, I would say, to partnering with the state and the hospitals to implement these funds and trying to get physicians being teachers in this space and rolling out the initiatives as they are approved following the RFPs. So lots of very exciting things happening at this time. I have rambled for a very long time, so I'm going to pass it back to Christina and we can open it up for questions. I know there's a lot